So after listening to the fact that metaphorically speaking and truly speaking, it was US that was throwing their weight around, but now it is India and China that is throwing its weight around. And I am happy from the metaphoric point of view, but not from the medical point of view, because I don't want the Chinese or the Indians to become obese. Mota moti, everything has been discussed about etiology, my disclosures, my disclaimers. Now we need to find a remedy for obesity management, and we need to identify the goals. The goals, of course, should be aimed at reducing body weight, maintaining the achieved lower body weight over a period of time, and then preventing it from going back. To set the goals for obesity management, you need the short-term goal, which is about 0.5 to 1 kilo per week, which could be 5 to 10% of weight loss. The interim goal should be maintain it. You have Ganpati festival, you have so many Diwalis coming, and you have to worry about how you will maintain what you lost. And the long term is achieve your target, keep your target there, and if you can manage, not bounce back at all, because that was your goal to begin with. Now, if you look at the management of obesity, I cannot take away the fact that lifestyle management, your kids and your treadmill with a beautiful dietitian comes first. Men don't like to listen to the diet that their wives tell them, but when the rosy red lipstick and pink cheeks girl tells you what you need to eat, what you don't need to eat, they swallow it. The same thing is the highest sales of kids is in the first week of the new year, because following Diwali, Christmas, New Year, the obesity surge and everybody wants to buy new shoes to walk. So lifestyle comes in at stage of BMI 25 to 28, BMI 28 to 30, and all the way up to 40. You cannot afford to ignore lifestyle. Pharmacotherapy, interesting, at 25 to 27 or 27 to 30, hardly any people would like to use the pharmacotherapy unless you have adiposity-related complications. But at higher levels, 30 to 35, 35 to 40 and plus, you definitely need pharmacotherapy. And if the pen does not work, the knife comes in. And the knife definitely comes in over 30, whether you have complications, whether your optimal medical management has failed, etc., etc. So all individuals, regardless of body size or composition, would benefit definitely with point 1, which is lifestyle, and I'm not going to talk about it except for the fact that a diet and physical activity, at least 60 minutes of physical activity, aerobic and resistance daily, or 300 minutes of activity per week. Hypocaloric diet, the diabetes prevention program has showed that minimum weight loss of 7% body weight through dietary modification is possible. 58% reduction in the incidence rate of diabetes with 180 minutes of moderate intensity physical activity. If you had a 5-day symposium of DRS in this center, we'd all be walking easily 10,000 steps, seeing how large the center is and how outspread everything is. Coming back to pharmacotherapy, the patient, the clinician, and of course the patient's family need to consider the obesity treatment. Information should be given to the patient, And then whether he has access, limited access, or full access, one has to advocate access, set the goals, look at contraindications, and then once started, assess efficacy, and efficacy monthly, 3 monthly, and look at goals. Where have you reached? If you don't reach, you need to escalate. If you, with escalation, fail, you need to change, as you will see in one of the cases. If one didn't work, you went to the other. And if the other didn't work, you also have an ultimate dual agonist. So reassessing the goals of treatment as you go along with the patient's values and the patient's desires to reach the target is really the practice of pharmacotherapy for obesity. What are the choices we have? Tirzepatide, start with 2.5 once a week. After 4 weeks, you keep stepping up till you reach 15 if you need to reach. I'm not saying you've got to go up. My practical experience tells me at 7.5 or even at 5, most of the Indian patients are consistently losing weight. I don't want to bowl a Bumrah if I'm getting wickets with somebody else. So if 5 and 7.5 are consistently giving me 2.5 to 3 kilos gone in a month, I would stay with that and see what my maintenance dose is. The maximum dose is only 15 and cannot exceed once a week, any time of the day, with or without meals. Then you have a second choice. Remember, tirzepatide is the dual, the GIP receptor and the GLP-1 receptor agonist. And it's been available now since 2023, CDSCO approved. Semaglutide 2021, again once a week. You can go up from 0.25, 0.5, you can even go 0.75, 1, 1.7, and keep going up to 2.4, which is the maximum dose. It is a GLP-1 receptor agonist. Again, you don't have to go to the maximum dose if you're reaching the interim goals, which are targeted to the final goals. And then, of course, I have to fill in the blanks and talk about orlistat, which is a reversible inhibitor of gastrointestinal lipases, but we hardly use it, so I'm not going to talk about it. Which comes where the bariatric or metabolic surgery comes in. Is the pen mightier than the knife? But the knife still remains dangling over your head if you don't succeed. So if you have people with BMIs of more than 35, regardless of presence, absence, or severity of obesity-related comorbidities, recent guidelines and surgical societies say, go for it. Previous guidelines talked about one obesity-related disease. There are lots of methods to do this. Several devices are available, but the decision for metabolic or bariatric surgery has to be a team decision. The patients and his relatives on the other side, the endocrinologist, the physician, and the surgeon on this side. And the outcomes amongst varying bariatric surgical procedures exist, from a sieve gastrectomy to a Roux-en-Y gastric bypass to an adjustable gastric banding. Lots of things are available. What began as an abdominal surgery then became endoscopic, laparoscopic. Now they even talk of mini quick procedures. Now I don't want to dwell on it because we have a surgeon talking about this. But remember, there are side effects, the dumping syndrome, the dysphagia, the vomiting, the GI problems of long-term issues. The GE reflex, the Barrett's esophagus, anastomotic ulcers, erosions, intolerance. These stay. With the pharma therapy, you overcome the GI side effects. Not because I am a physician that I am trying to play up this, but I've seen my metabolic or bariatric patients coming with these long-term issues, but the results are fabulous, having said that. So a patient with diabetes and obesity, 50-year-old guy who had diabetes for 10 years, BMI 36, A1C 8.5, 10 years duration of diabetes, 95 kilos, hypertensive. He was on metformin, Sita, Empa, and then he was trying to take semaglutide, went up to 7, could not tolerate, and of course he was on telmisartan. What would your treatment approach be to this patient to improve his sugars and to reduce weight? Pharmacotherapy further to lower A1C? Of course, lifestyle, exercise, pharmacotherapy is very important, and this is where we need to consider what is the treatment approach. Would you only want to lower A1C? Would you also look at both these things, or you want also weight? The answer is a sine qua non, and it's only a poser which is put to you. Now, this is another patient with obesity but without diabetes. 45-year-old male, 34 BMI, 105 kilos, 7 years obese, also hypertensive. He was put on lifestyle intervention for 3 months with diet and exercise. After 4 months of feeling a little better and the step counter on his phone showing 6,000 steps a day, he was disappointed with the scales when after a while he only dropped 2 kilos. And this is something which we need to remember. This is where what Dr. A.K. Das said, obesity is a disease. It's a chronic disease where you can lose something, but it comes back. And if you do not hit it at that time, this bounce back of obesity, this increase in the chronic disease is when the complications don't creep in, they run in. So you have to look at the fact that there are lots of comorbidities of these patients and you have to treat them quickly. Think of a dual GLP-1 and GIP agonist. Dosing is similar whether you're using it for type 2 diabetes or for chronic obesity. Maintenance dose I talked about. What about coexistence and how you use it with metformin, SGL2, T2s? Continue both of them. They all will add to it. Sulfonylurea and or insulin, obviously you'll have to reduce the doses, keeping the sugars in mind. No dose adjustment on age, gender, race, ethnicity, but not allowed under 18. You have to be careful. Nothing is required for hepatic or renal, but the experience of patients in hepatic severe impairment or ESRD is limited. Practical considerations, pancreatitis is a red light. Be careful. There are laws and rules how you can use that. Pregnancy, it has not been used, so I wouldn't use it. Breastfeeding also, we don't have experience. Diabetic retinopathy, the non-proliferative and the proliferative, the data is limited, as is with diabetic macular edema, so be careful. Use it early before retinitis sets in. Education of GI side effects is simple. Eat small portions, eat frequently if you have to. Once you feel a little full, stop eating. And avoid eating when you're not hungry. Just because Pavlov's ring has happened doesn't mean you get the bell in your mouth and start salivating. Stay well hydrated. Avoid the wrong kinds of foods and limit what happens today after 8:30. The fizzy drinks and the alcohol you have to limit. If you miss a dose and if you're less than 4 days into having missed it, take it immediately and get back into the schedule. If you missed more than 4 days, you had a fight either with your wife or with the lovely lady who comes to inject it, We'll wait till next week's turn and get back into it. In summary, obesity management involves permission, assessment, advice, goal setting, and support. You have to be proactive. हाँ आप थोड़ा चलो, सीढ़ी चढ़ो, खाना ये नहीं खाओ, वो नहीं खाओ. This is a disease. What people used to say, okay, go and lose weight, you have to make them lose weight. BMI and complications guide treatment through the 3 components. Lifestyle change alone is not enough. Lots of surgical and pharma options available. Set the goal with the patient. Everybody's obesity, you have to tailor-made for that patient. I think having said that, I will stop and let's see what we hear from the knife.
Yes, Hemant, please join here.